So I am excited to welcome our speaker, Megan McElfresh, who joins us again to close out our webinar series for 2023, as she closed us out for 2022 also. So she will be talking to us today about CAR T 101, overview of CAR T therapy and management of toxicities. So our presenter today, Megan McElfresh, graduated from Gardner-Webb University in December of 2009 with a BA in biology and a minor in math and chemistry. She then worked for a year as a nursing assistant before attending PA school. Megan graduated from Methodist University with a master's in medical science in 2013 and became a board-certified physician assistant. She has been working at UNC in the bone marrow transplant and cellular therapy program since August of 2014. So Megan loves spending her free time hanging out with family or reading, listening to audiobooks and podcasts. So Megan, a favorite podcast to share with the audience?
I love any crime podcast, so Crime Junkie. And recently I've really been into one called De-Influenced. So it's kind of the opposite of all the influencers that are out there.
Okay, thank you for sharing. So here is an example of our poll everywhere questions. You will have a chance to test this in a moment. So our first test question is, CAR T immunotherapy is the re-engineering of cells from a patient's immune system to create modified cells that are designed to recognize and direct the attack against the patient's cancer. True or false? I will circle back to this in a moment. Here are our disclosures. So you can test your poll everywhere for this first question. And we have some answers coming through. Looks like 100% true. How'd they do, Megan?
That is correct.
Great. So now I will turn it over to Megan. Thank you.
Thank you so much, Tammy. Once again, I'm Megan. I'm one of the PAs with the bone marrow transplant and cellular therapy program. And today I'll be presenting CAR T 101, an overview of CAR T therapy and management of toxicities. So objectives for today, describe the collection process and the purpose of CAR T cells, describe the side effects of CAR T cells, describe the treatment for cytokine release syndrome post-CAR T, and describe the treatment of neurotoxicity post-CAR T. So what is CAR T? CAR T is a type of immunotherapy, which is a treatment that utilizes your body's own immune system to fight cancer. So to really understand CAR T, you kind of have to understand your immune system. So we all have lymphocytes, which are a subset of white blood cells that comprise the large portion of our immune system, and those can be broken down into three different types. We have B lymphocytes or B cells, which help to kill off infections through antibodies. We have T cells or T lymphocytes. These have multiple functions. One is to aid B cells in creating those antibodies, as well as just directly killing off infection or foreign cells. And then natural killer cells or NK cells. And these directly attack infections or help to eliminate viruses. So considering our immune system, it can easily recognize foreign substances such as infection or cancer cells by detecting proteins or antigens on those cells. And then our immune system itself, through T cells and the other lymphocytes, can then use proteins called receptors to attach to those antigens and kill off those foreign substances. So thinking through the antigen receptor relationship as kind of a lock and key system, locks have one specific key design that they need to kind of open that lock or close that lock. Similarly, if we have foreign cells in our body, they have an antigen that has one specific receptor that can then attach to that antigen and destroy that cell. So if you have cancer cells in your body and you don't have receptors to attach to the antigen of the cells and kill it off, they're going to continue to multiply. So the goal of CAR T is kind of to have those receptors there to attach to antigens. So CAR T therapy, CAR T actually stands for chimeric antigen receptor T cell therapy. This is a therapy aimed at getting your immune cells, or those T cells, to fight cancer by altering them in a lab. And when we alter them in a lab, we're introducing this CAR gene to the T cells so that they can then go and find and destroy cancer cells. Cancer often develops when tumor cells evade our immune surveillance or suppress the immune response, which then can lead to proliferation or multiplication of those cancer cells. So again, the goal of CAR T is to try to overcome that immune tolerance. This image here on the right can depict the process of collecting CAR T cells all the way through reinfusing them. So first T cells are collected from a patient. That would be through step 1, and then T cells are re-engineered in a lab. This is where the CAR gene is introduced into the T cells and the receptors are produced. That's steps 2 and 3. And then the cells are then allowed to expand or multiply, which would be step 4. Then the patients receive chemotherapy, which is step 5. And then step 6 would be actually getting the CAR T cells infused. So we're going to break down each of these steps a little bit more. So T cell collection, this is going to be our first step. This can be through a blood draw or through apheresis collection. Most of the time for our CAR T patients, it is through the apheresis collection, which is also leukapheresis. This typically involves having 2 peripheral IVs or a central line that has 2 lumens. And then the patient in the apheresis lab, their blood is pulled from one of the IVs or one of the lumens. It goes to an apheresis machine. This machine then pheresis out the white blood cells or the T cells. And then through the second IV or lumen, the blood's put back into the body. This can be a lengthy process. It can take 3 to 5 hours. And then patients can also have electrolyte abnormalities with this. More common, we can see a drop in their calcium. So they may need some calcium replacement with this as well. And then whole blood collection, while it is much quicker, it's just a blood draw, is not used very often. It typically can just be used if we need just a small amount of starting cells. And then the way that they get alpha T cells is through density gradient centrifugation, and that's to remove the red blood cells and granulocytes. The next step in the process is going to be the cell re-engineering or expansion. And this is actually a multi-step manufacturing process. So the image here at the bottom kind of shows each step. So on the left, we have our apheresis product. That's the collected T cells. They then go to a lab, and the first step is washing. This is mainly to remove any anticoagulants that were introduced during the collection process, or to eliminate any remaining red blood cells or platelets. The next step is activation. This is actually stimulating those T cells, and that can be done through different stimulation pathways and culture media. And then the next step would be the actual gene delivery. And this is adding that CAR transgene to the T cells. This is typically done with lentiviral or retroviral, and in some cases, non-viral methods. And then expansion is just allowing those cells to grow and multiply in number. And then for formulation and filling, that is where once the cells have been allowed to grow, the cell number and the collection product is manipulated based on the formulation. So example, if you had cells that needed to be frozen, you may need to introduce a cryopreservation type media. Then the cells are put into their allotted container and either frozen or brought back to where the patient is. And the last step is that product is available to be infused into the patient. Our next step would be lymphodepletion. This is lymphodepleting conditioning regimens, which are chemotherapy regimens, and they are essential to the success of CAR T cells. This chart here kind of really shows different effects of the lymphodepletion. Really, we'll focus on the left side. So lymphodepletion, of course, has the effect of depleting our lymphocytes. So it's going to lower those total NK, B, and T cells, which that really helps to lower the immune system. And so there's fewer anti-CAR T cell immune responses. It helps to eradicate immune suppressor cells. It helps to modulate tumor suppressive effects, helps to eliminate the homeostatic cytokine sink, and then it increases expansion, function, and persistence of our CAR T cells. So really the purpose of lymphodepletion is to lower the baseline immune system of the patient, and that can allow for persistence of CAR T cells and overall better effectiveness. So lymphodepletion, we typically use fludarabine and cyclophosphamide. They're typically given over 3 days. There are some regimens that are fludarabine and bendamustine. Those are usually more for trial lymphoma CARs. And usually these are lower doses of chemotherapy than what we would typically give for like conditioning for transplant. So fludarabine is typically 30 milligrams per meter squared per day. Cyclophosphamide could be 300 or 500 milligrams per meter squared per day. And then bendamustine, if that's used, is usually 70 milligrams per meter squared per day. And again, usually a 3-day regimen. This is typically given a week before the CAR T cell infusion, with a requirement of a minimum of 2 days of rest between chemo and cell infusion. And the reason we have that rest built in is mainly to mitigate any negative effects of the chemo on the cells themselves once they're infused. So the chemo, even though it's lower dosing, there are still potential side effects or toxicities from that. Some of them are the common pancytopenia, prolonged immune suppression that we can see from most chemos. There's also potential of increased risk of secondary malignancies, such as treatment-related MDS. Fludarabine itself has a risk of fever and neurotoxicity, and cyclophosphamide has a risk of hemorrhagic cystitis and pericarditis. Both chemotherapies and bendamustine as well all have risk of GI side effects, similar to other chemos, so nausea, vomiting, diarrhea. So it's also important to make sure our patients have antiemetics and antidiarrheals as well. And then our last step is going to be cell infusion. So cells are infused through a peripheral IV or central lines, similar to a blood transfusion. These can be performed outpatient or inpatient. And then there's typically an allotted time for monitoring, and this is different based on if it's out or inpatient. So outpatient, the cells are usually given in our infusion center. The cell infusion itself is usually pretty quick, but there's an allotted several hours that they are monitored afterwards in infusion for any potential infusion reactions or early onset toxicities. And then for outpatient, we typically will see them once a day for that first week, just because of the high risk of toxicities. And then inpatient, they're going to be monitored the day of the cell infusion, and then they typically stay for a week to get that kind of daily monitoring. And then often we will give pre-medications before to help prevent any potential side effects of infusion reactions. So Tylenol or Benadryl or Zyrtec are given. This kind of just highlights the timeline between referral and cell infusion, which unfortunately can be a little lengthy. So first we have to obtain insurance authorization. This can take days to weeks. And then we have to collect the patient's T cells, again, typically done through apheresis, which is a longer process than a blood draw. And if a patient needs to go to apheresis, they often are going to need a central line placement if they don't have good peripheral access. So you're then waiting to get them scheduled for line placement and then scheduled for an apheresis slot. Once the cells have been collected, they then have to go to the lab to be manufactured through quality control. That can take 2 to 6 weeks. So often during that time frame, patients may need bridging therapy to try to help prevent progression. And then patients will get their lymphodepleting chemo, typically 3 days, and then the CAR T cells are usually given 2 to 4 days after that. So unfortunately, because of the length of time that can occur between referral and the actual infusion, there are some patients that don't make it to the time of infusion because their disease has progressed. One of the challenges with developing CAR T cells, or multiple challenges that have occurred, is mainly finding that suitable target, that antigen. So we know that the target has to be on multiple universal surfaces of malignant cells. So it needs to be one that is on all of the malignant cells, but that also raises the risk of what's called an on-target off-tumor toxicity. So this image kind of depicts that, which we'll talk about a little bit later on as well. But You can see here the malignant B cells have the CD19 antigen, but that's also on normal B cells. And so if you have a CAR T against CD19, it can kill off the cancer cells, but also kill off some of the normal cells as well. Currently, examples of antigens that we use for CAR T are CD19, BCMA, and CD30. This is kind of a breakdown of the different antigens based on different cancer types that we currently use. So for ALL, we have a CD19, lymphomas have CD19 and CD30. And then here at UNC, we have a CD30 with what's called a CCR4 antigen receptor. And then for multiple myeloma, we have BCMA. And then at UNC, we have a CD138. For solid tumors, there's actually something called a CAR McElfresh, and this is a HER2 one. This is typically used for breast cancer, head and neck cancer, lung cancers, more of the solid tumors. And then there's a BCH3 that's for ovarian cancer. We also now have a B7H3 for glioblastoma as well. Pemphigus is actually a chimeric autoantibody receptor. And then myasthenia gravis is another BCMA. So going through some of our different CAR T products, I wanted to kind of highlight the lengthy timeline of the development of CAR Ts. We typically think of CAR T as a more recent type of therapy, but they really started engineering them quite a while ago. So 1992, the first T cell engineering began. And then in 1993, there was a first generation CAR T developed, but it didn't persist in the body. So it wasn't considered clinically effective. And then in 1994, some antigen specific T cells were used in humans, and these were virus specific. So they were used to prevent post-transplant infections and virally mediated cancers such as CMV or EBV. And then in 1998, there was a co-stimulation that showed a necessary boost. So the CD28 co-stimulatory molecule was introduced into the T cells, and this actually allowed them to persist in the body. And then in 2002, the first effective CAR T cell was developed. This was actually at MSK, and it targeted prostate cancer antigens. And then in 2003, the second generation CAR T cells were developed. And again, it was really against that CD19. That's the first antigen for those. And then there's a length of time between the first development until the first CARs actually crossed the regulatory finish line. So 2017, the first CD19 CAR T therapy was developed and FDA approved. And this was for ALL. So this is our CD19 CAR T for ALL. The first FDA approved is Kymriah. It was approved in 2017, and it's used for relapse refractory B-cell ALL in pediatric and young adults, so patients less than 25. And this was based on the ELENA trial. This was a pivotal trial, phase 2, that actually showed CR rates of 83% for patients receiving Kymriah, and progression-free survival at 18 months was 66%. And then in 2021, another product was approved called Tecartus, and this is for adult patients with relapse refractory B-cell ALL, so patients that are above that 25-year-old cutoff. And then there's been a large data analysis from 12 different studies looking at CD19 CARs for ALL. And this analysis shows that initial CR rates ranged from 62 to 86%, with the majority of these being what we call deep or minimal residual disease negative remissions. Next, we'll look at our CD19 CARs for lymphoma. So there's 3 FDA-approved products, and they are for relapse refractory large cell lymphoma. We have Yescarta, which is approved in 2017. Kymriah was approved in 2018, and then Breyanzi approved in 2021. That same large data analysis looked at 10 studies for CD19 CARs for lymphoma, which showed overall response rates of 44 to 91% and CR response rates of 28 to 68%. And then we have our BCMA CARs for multiple myeloma. First was Abecma, which is approved in March of 2021. This CAR has a similar toxicity to the prior CD19 CARs, which we'll talk a little more on those toxicities in a bit. But one caveat with Abecma is that those toxicities usually have an earlier onset. And then a second anti-BCMA CAR called Carvykti is now approved, and we're in the process of getting this here at UNC. This one actually has a slightly different toxicity profile, especially from the neurologic side, so that we can see things like Parkinson's, Guillain-Barré, peripheral neuropathies, cranial nerve palsies, and that's a little more than what we've seen with other CAR-Ts. And one of the other things with the new Carvykti one is that those toxicities tend to happen later than what we would expect with our other CAR-Ts. So data from 6 studies looking at BCMA treatment CARs for multiple myeloma showed overall response rates of 73 to 100% and CR or stringent CR rates from 33 to 83%. So this chart just kind of shows our current commercial CAR-Ts. So we have Yescarta, which targets CD19 for diffuse large B-cell and follicular lymphoma. Tecartus also targets CD19 for mantle cell or adult ALL. Breyanzi, CD19 for diffuse large B-cell. Kymriah has a CD19 for diffuse large B-cell and follicular, as well as B-cell ALL for young adults. And then Abecma BCMA for multiple myeloma. And then we can now also add Carvykti to this, which is another BCMA for multiple myeloma. So next, let's talk about some of the toxicities from CAR-T and the management of those toxicities. So there's a wide range of toxicities that we can see, but the 2 most common that we'll go a little more in depth on today are going to be CRS and neurotoxicity. But there's also risk of macrophage activation syndrome, tumor lysis syndrome, B-cell aplasia, cytopenia, and infections. So we'll touch on those as well. So first is CRS, or cytokine release syndrome. This is actually the most common and most expected toxicity from CAR-T therapy. It typically occurs because of cytokine release when the CAR cells attach to the cancer cells and kill them off. And there's this mass release of cytokines, which can actually cause this really large systemic inflammatory response. And so we can often see elevation in inflammatory markers during CRS. So often CRP will go up, ferritin will go up, LDH will go up, IL-6 will go up, and then fibrinogen actually can go down during CRS. So we've seen some patients require cryo transfusions during this. CRS can occur between 1 to 21 days post-CAR-T, but typically it's more on the earlier side, usually between days 2 and 7. There's a wide range of symptoms from mild flu-like to more severe, and we'll go a little more in depth on those, as well as the grading scale. It's graded on a scale of 1 to 4. So some of the signs and symptoms. Mild symptoms include nausea, fatigue, headache, chills, and then fever. Fever is bold here because that is the most common symptom, and you would not see CRS without a fever. The more serious symptoms that we can see typically are driven from that severe inflammatory process. So patients can develop hemodynamic instability with hypotension, tachycardia, capillary leak, cardiac arrest, cardiac arrhythmias, cardiac failure. That macrophage activation syndrome, which we'll touch base on in a little bit, is really just severe CRS, hypoxia, renal insufficiency, and then multi-organ failure. Some of the risk factors for developing more severe CRS, one would be bulky disease. So if you come to CAR-T with a high tumor burden or a very large white count, we have more cancer cells that we're killing off, so more cytokines are being released. Typically, patients that have 2 or more comorbidities are going to be at higher risk, especially if they have comorbidities affecting their heart, lungs, or any of their GI type things, hepatic system. And then early onset CRS is actually a risk factor. So if patients develop CRS within the first 72 hours of CAR infusion, they have higher risk of then progressing to more severe CRS. Older age is a risk factor, so anyone over 60 receiving CAR. And then certain CAR T products themselves have higher risk. So Abecma, we had mentioned, has an earlier onset of CRS, so that again poses that higher risk. And then Yescarta and Tecartus also have pretty high risk of CRS and neurotoxicity. So the grading scale for CRS, again, is a 1 to 4, with 1 being more mild and grade 4 being more severe. So grade 1 would be fever only. Grade 2 is going to be fever plus hypotension. Hypotension is typically going to be responsive to just fluid and or hypoxia that's requiring less than or equal to 6 liters of nasal cannula. Grade 2 or grade 3 is going to be all of the same factors from grade 2, but then the hypotension often is requiring pressor management, usually with just 1 pressor. And for hypoxia, patients may progress to needing high flow oxygen. And then grade 4 is going to be similar to grade 3, but patients may now be on multiple pressors to manage their hypotension, or positive pressure O2, such as vent, BiPAP, or CPAP to manage their hypoxia. Typically, if patients are in that grade 3 to 4 for CRS, they're going to be transferred off our floor to more of a high intensity type unit for better monitoring. So one of the treatments we use for CRS is tocilizumab. This is an anti-IL-6 receptor antibody. And the reason that that can work with CRS is because we know with CRS and the cytokine release, IL-6 is really a mediator for that. Early on, there was concern that treating the inflammatory process could potentially cut off CAR T cells, but studies have shown that the use of tocilizumab does not seem to affect the efficacy of CAR T cell therapy. So we are pretty quick to use this as patients progress with CRS. Once a patient receives tocilizumab, their fever often resolves pretty quickly. It can be within a few hours to 24 hours. And then pressors and other supportive care can often be weaned off pretty quickly at that point. The dosing for tocilizumab is 8 milligrams per kilogram, typically given IV over an hour, and it can be repeated every 8 hours. The max dose is typically 4 doses. And what we typically do for our CAR T patients is the day of cell infusion or the day before, our pharmacist will actually check to ensure that there are at least 2 doses of tocilizumab on site allotted for our CAR T patient. This was a concern early on with COVID when a lot of patients were getting tocilizumab with COVID, but now is typically not a problem to have doses for our patients. Another potential treatment option for CRS is corticosteroids. We know that there's this large inflammatory response and that steroids typically can help suppress inflammation. This can suppress the T cell function, and so there's a potential risk of inducing T cell apoptosis. So there has been concern that using steroids could interfere with the efficacy of CAR T cell therapy. However, recent data has kind of brought this into question, and it doesn't seem that they're quite as suppressive as we originally thought, especially in our lymphoma patients. So we're not quite as hesitant to use steroids as needed. So the treatment for CRS and kind of what to choose and when is based on that grading scale. So for grade 1, if a patient just has a fever, we typically just do symptomatic management. We give Tylenol to help break the fever. If they're having any nausea, they can have antiemetics. Any pain is treated with pain medication. One thing we do consider if patients have persistent fever, so a persistent grade 1 CRS for over 24 hours, then we may consider tocilizumab. And if patients persist and have grade 1 with a fever more than 72 hours, then we will go ahead and give tocilizumab. And then for grade 2, we typically will give tocilizumab and then consider potentially steroids. And the option to give steroids is usually based on those patients that have those higher risk features. So if it's someone with bulky disease, if they come in with multiple comorbidities or they're older, then we may consider starting steroids at only grade 2. The typical starting dose for this is going to be dexamethasone 4 milligrams IV twice a day, and you can progress that as needed, especially for the higher grades. And so grade 3 tocilizumab plus steroids, usually for that it's going to be the dexamethasone again as well. You can increase all the way up to 20 milligrams IV as needed. And then for grade 4, or if they're not responding to dexamethasone, you can also consider methylpred as well. Other considerations in patients that have CRS, we know that fever is going to occur if a patient has CRS, but these patients that have received lymphodepleting chemo are often neutropenic. So there's also the concern of infection as well. And so typically we plan to have infectious workup and administer antibiotics at the same time as treating for CRS. So our first patient question here, you have a 60-year-old patient with diffuse large B-cell treated with Yescarta, which is a CD19 CAR. They develop a fever of 40 degrees Celsius 2 days after CAR T infusion. She also has tachycardia, fatigue, and decreased appetite. What grade of CRS would this be? A, grade 1, B, grade 2, C, grade 3, or D, grade 4? We'll give you guys a minute to answer. So we've got a mixture of grade 2, grade 1. So the correct answer is grade 1 CRS. Because they only have a fever at this point, it's considered grade 1. If the patient started to develop hypotension or hypoxia, then they would progress to further grades. Now that you've determined your patient has possible grade 1 CRS, what would be the initial next steps? A, give Tylenol for fever and monitor vital signs. B, start tocilizumab alone. C, send blood cultures, start broad-spectrum antibiotics, give Tylenol PRN for fever, monitor vital signs for progression to grade 2 or higher. Or D, start tocilizumab, start broad-spectrum antibiotics, check blood cultures, and give Tylenol PRN for fever. We've got a little bit of mix between A and C. So the correct answer is C. They have grade 1, so we typically aren't going to start tocilizumab at this point unless they have persistent fevers over at least 24 hours. But because they have a fever, you still want to rule out infection because they are neutropenic, usually at this point. So you're going to send those blood cultures and get antibiotics going as well, and then still monitor for any further progression of their CRS. Next, let's talk about ICANS, which is immune effector cell associated neurotoxicity syndrome. We typically just refer to it as neurotoxicity or ICANS. The mechanism of action for this is a little unknown. So we know that there's this systemic inflammation, release of cytokines that occurs, especially during that CRS process. And the thought is that this can cause a cascade of blood-brain barrier disruption, increased vascular permeability, and endothelial cell activation. And then you can see increased cytokines in the CSF. Usually neurotoxicity occurs within the first 2 weeks post-CAR, but can occur up to 8 weeks after. So we often, for most of our CAR patients, have a requirement of no driving for 8 weeks post-CAR T. And this can occur in conjunction with CRS, but typically it will occur later once CRS has subsided. And patients don't have to have CRS to get neurotoxicity and vice versa, but they can occur at the same time or separately. This image here kind of just depicts the mechanism of action. The bottom half really shows that CRS type picture where there's lots of inflammation, cytokines are being released, and then the thought is that those cytokines kind of alter the blood-brain barrier, increase that vascular permeability, and then they can have endothelial activation, and then you can see those cytokines actually in the CSF. And this can lead to some of the side effects we can see with neurotoxicity, such as delirium, aphasia, seizures, cerebral edema, as well as intracranial hemorrhage. That hemodynamic instability that's listed is typically what we can see with that kind of cytokine release. There's tachycardia, hypotension, capillary leak, as well as some organ injuries, AST, ALT, and hyperbiliary if there's hepatic injury, as well as respiratory failure. So signs and symptoms of neurotoxicity. Patients typically present with toxic encephalopathy. This is usually seen with diminished attention, maybe some memory loss, language disturbances, aphasia, impaired handwriting is often related to tremors. And then some of the more severe symptoms we can see are things such as seizures, motor weakness, increased intracranial pressure, papilledema, cerebral edema, or even unresponsiveness. In the moment, for caregivers as well as staff, patients that have severe neurotoxicity, especially if they become comatose or unresponsive, it can be a scary situation. But the positive thing is that often symptoms are reversible if they're treated early, and the typical treatment we'll go over is steroids. So one way that we diagnose neurotoxicity is with what's called an ICE score. So it's an immune effector cell encephalopathy score. This is typically done at every clinic visit for our outpatient folks, and then once a shift for our inpatient folks. And it's a score of 10 would be normal, and anything less than that would be signs of neurotoxicity. So typically we ask the typical orientation questions. What year is it? What month is it? What city are you in? What hospital are you at? And then we have them name 3 objects in the room. We have them follow a simple command, which is typically close your eyes and raise X number of fingers. And then we have them write a sentence. We're not really focused here on grading their grammar, but we want to make sure, one, they're writing a coherent sentence, but also are there changes to their handwriting? So we try to get a baseline sentence before they get their CAR T-cell infusion. And the main reason is we can see changes in handwriting if patients start to develop a tremor, which can be an early sign of neurotoxicity. And then we have them count backwards from 100 by 10, and this is mainly to test their attention. And then we'll give them a score afterwards. So neurotoxicity, similar to CRS, is graded from 1 to 4. This grading is typically based on their ICE score. So a score of 7 to 9 is going to be grade 1. A score of 3 to 6 is going to be grade 2. Score of 0 or 1 to 2 is a grade 3. And then a score of 0 for grade 4 is typically patients that are comatose, unarousable. They just can't perform the ICE score at all. We do sometimes use level of consciousness to also guide our grading for neurotoxicity. So if a patient awakens spontaneously, that's grade 1. If they awaken to voice, that's grade 2. If they awaken only to tactile stimuli, grade 3. And if they're, again, unarousable, if they're in a stupor or comatose, that's a grade 4. We typically don't see seizures with grade 1 or 2, but we can see clinical seizures, focal or generalized. But if they resolve rapidly, or non-convulsive seizures on EEG that resolve with intervention, that would be grade 3. And then grade 4 are going to be life-threatening, prolonged seizures, typically greater than 5 minutes, or repetitive clinical or electrical seizures without return to baseline. We typically don't see motor findings other than in grade 4, and these would be deep focal motor weakness, such as hemiparesis or paraparesis. And then we can see increased intracranial pressure or cerebral edema, typically with just grade 3 or 4. So grade 3 would be focal or local edema on imaging, but grade 4 would be diffuse cerebral edema. Patients can have decelerate undercorticate posturing, cranial nerve palsies, papilledema, or Cushing's triad. And Cushing's triad is just a sign of acute increase in intracranial pressure. This is typically seen in changes in their vital signs. So patients can have bradycardia, they can have irregular respirations or breathing, and then a wide pulse pressure. So they have increases in their systolic pressure and decreases in their diastolic. So management for neurotoxicity. again, is based on the grade. So grade 1 is typically going to be supportive measures. We will often start patients on Keppra to help prevent seizures if they're not already on this. And then we go ahead and consult neurology at just grade 1. The main reason is patients with neurotoxicity can progress pretty quickly. So we want to try to get neuro involved early on. And then grade 2 to 4, similar to grade 1, but we're going to add steroids. The typical starting dose for grade 2 is going to be dexamethasone, 10 IV Q6 to 12 hours until they improve to grade 1 and then taper. Grade 3 it can be that same dosing and can increase up to dex 20 milligrams IV. And then for grade 4, we often are going to consider methylpred, and that's typically 500 milligrams IV twice a day, and then you taper after 3 days. If a patient does develop a seizure during neurotoxicity, you would treat that with standard anti-epileptic therapy. And then other considerations for workup would be brain MRI. This is really imaging to check for cerebral edema or other potential causes of mental status changes. An LP, which is going to be used typically to check an opening pressure, but also rule out any infections in the CSF that may be causing mental status changes. And then an EEG is going to be used to rule out seizures. One caveat with neurotoxicity is that we typically don't treat this with tocilizumab. And the reason is that tocilizumab doesn't cross the blood-brain barrier, so it's thought to not be effective in treating neurotoxicity. However, if a patient has concurrent CRS and neurotoxicity, you may use tocilizumab to treat the CRS per CRS guidelines. This is just a picture depicting cerebral edema, which we can see in our patients if we get brain MRIs on them during CAR-T. We don't always get one, but it's a potential tool to help look for that cerebral edema. And then one caveat for one of our CAR-Ts, Yescarta, it does have a high risk of CRS and neurotoxicity. So we now, for our diffuse large B-cell patients getting Yescarta, give prophylaxis to try to prevent these toxicities. And we actually will give dexamethasone 10 milligrams orally for 3 days, and it starts on day of cell infusion. Another potential prophylaxis is Keppra. This isn't used to potentially prevent neurotoxicity, but would be to prevent seizures if a patient develops neurotoxicity. We use this for patients with higher risk of ICANS, so usually patients getting Yescarta or Tecartus, or if someone has known CNS involvement, we may go ahead and prophylax them with Keppra. The doses we use, we typically start at 500 twice a day, and that starts on day 0, a day of cell infusion, and that continues for 3 weeks, and then 500 daily for a week, and then 250 daily for a week. If a patient has a seizure during neurotoxicity and requires Keppra as a treatment, we typically defer tapering of that to outpatient neurology. And then one other possible treatment option is anakinra. This is a newer treatment option. It's a potential treatment for refractory CRS or ICANS. I've mainly seen it used in patients that have refractory ICANS. It would be considered a second or third line agent for treatment. It is an IL-1 receptor blocker, and it's typically dosed as 100 milligrams sub-Q daily. There are ongoing trials that are investigating the early use of this or even the prophylactic use of anakinra. And then one thing I just wanted to point out briefly, we do have treatment guidelines for CRS, ICANS for adults and pediatrics on our UNC internet page, and it can be found under the BMT cellular therapy page. The main reason we want to have those out there, not only for our own group, but for other groups throughout the hospital that may be managing our patients, especially the ER or infusion center if these patients are coming in for admission. So next case question, you have a 52-year-old male with diffuse large B-cell, received Yescarta. On day 6, he developed a hand tremor, mental status changes. You perform an I-score. He's unable to count backwards. He's unable to tell you what city or hospital he's in or write a sentence. He has an I-score of 6. What grade ICANS does he have? So it doesn't have the options on there, but grade, oh, there we go. Grade 1, B would be grade 2, C grade 3, or D, grade 4. We've got a little mix between grade 2, grade 3. So the correct answer is grade 2. So again, it's based on that ICE score. So an ICE score of 7 to 9 would be grade 1, but this patient had an ICE score of 6, so that would be grade 2. Now that you've determined he has grade 2 ICANS and no associated CRS, how would you treat this? A, start tocilizumab, B, start anakinra, C, start dexamethasone, or D, start all of the above. And it looks like we've got 100% correct. You're going to start dexamethasone. So we typically aren't going to use tocilizumab because there was no concurrent CRS. And then anakinra, we're going to reserve if they're refractory to dexamethasone. So let's talk about some of the other toxicities. Macrophage activation syndrome. This can be seen more routinely in patients that already have underlying rheumatologic disorders, such as juvenile rheumatoid arthritis. And it's basically uncontrolled activation and proliferation of macrophages and T lymphocytes with a marked increase in circulating cytokines. So it's CRS that's now out of control with marked inflammation resulting. It can cause hepatosplenomegaly, DIC, and pancytopenia. This is something that should be considered if patients have ongoing CRS and then have a peak ferritin of over 10,000, as well as develop LFT abnormalities, AKI, or pulmonary edema. Because this is another marked inflammatory type picture, the management is going to be the same as CRS, so typically with tocilizumab and steroids. Another potential side effect is tumor lysis syndrome. This can often occur while patients are undergoing lymphodepleting chemo, but could potentially be delayed in the CAR T therapy around the time of cell proliferation. And this is caused by the release of lysed tumor cell content and can often lead to renal failure and electrolyte abnormalities. We can often see hyperuricemia, hypercalcemia, hyperphosphatemia, and then hypocalcemia, and then AKI as well. And because of the electrolyte abnormalities, we often recommend frequent monitoring of the chemistry panel, so Q12 or Q8 chemistries. We see this more often in patients that have large tumor burden or get CD19 CARs. So if you have a high burden of disease, you're going to be lysing more of those tumor cells and have risk of this. We do sometimes put patients on prophylaxis with allopurinol. Usually that'll start on day of lymphodepletion and continue for a week post CAR T infusion to help try to prevent this. And then sometimes if patients develop tumor lysis, we will put them on hydration for treatment. In more severe cases, we will use respiricase for treatment as well. And then B-cell aplasia or hypogammaglobulinemia. This again is that on-target off-tumor toxicity, specifically with CD19 CARs. So this image, similar to the one we saw previously, you have malignant cells that have that CD19 antigen, and then you have naive and memory B cells that also have that same antigen. So you give this CAR T that has a receptor for the CD19 antigen, and it's going to kill off the malignant cells, which we want, but also potentially kill off our normal good B cells as well. This can lead to frequent infections, prolonged immune suppression. So in adults, we typically don't treat with IVIG unless the patient is having frequent infections or if they have significantly low IgG levels. So often if their IgG is less than 400, and you can monitor IgG levels post-CAR. We don't recommend typically starting that until at least a month out. Cytopenias, patients may develop persistent cytopenia greater than 1 month for about a third of our patients who get CD19 directed CAR T cells. This often resolves by 3 months for most patients, but some can have even more persistent low counts. Typically, we see that with neutropenia or thrombocytopenia. You can give growth factor or transfusions if needed. One caveat with growth factor is there have been some studies recently that show potential risk of developing CRS if you give growth factor. So we try to reserve to not give that before day 14 for our commercial CARs and before day 30 for trials. And then also considering potentially treatment-related MDS if patients have really persistent cytopenias. And then because of these ongoing cytopenias and the lymphodepletion chemo, patients do have risk of infection. Infection risk factors include extensive prior treatment even before CAR-T, the lymphodepleting chemo, treatment for CRS and ICANS with those anti-inflammatory type treatments, and then that B-cell aplasia. Patients have high risk for opportunistic infections even out to 1 year from their CAR-T, especially viral infections and PJP. So you can kind of break down the phases of toxicity into 3 phases. Our acutes, the first 30 days, this is usually that CRS ICANS, and then kind of generalized infections because of neutropenia, bacteremia, C. diff, pneumonias, multiple viral infections, as well as Candida fungal infections, potential risk for aspergillus and non-aspergillus in kind of the later portion of that phase as well. And then the second phase, delayed toxicities, are going to be the day 30 to day 90. These are usually from impaired cellular and humoral immunity. Usually we can see still some pneumonias, HSV, VZV, the typical seasonal respiratory infections, still a little bit of risk of aspergillus and non-aspergillus molds, and then still that pneumocystis comes into play. And then late phase is going to be day 90 to 1 year. And this is usually related to that persistent CD19 B-cell aplasia or hypogammaglobulinemia. Again, often can see pneumonias, HSV, VZV, those seasonal respiratory viruses, and still for a bit that pneumocystis as well. So we do recommend prophylaxis to prevent infections. We typically start Valtrex on day of cell infusion and continue for 1 year. We typically will give Levaquin and fluconazole if patients are neutropenic with an ANC of less than 0.5. Bactrim or other PJP prophylaxis is recommended to start at day 30 and continue through 1 year or until their CD4 count recovers above 200. Typically that's recommended to start checking at 3 months post-CAR-T. And then lastly, I wanted to touch base on some of the UNC studies we have going on for CAR-T. This graph just kind of lists the different ones. First was a CD30 CAR for lymphoma. There has been an article published on some of this data in PubMed. There were 41 patients between UNC and Baylor that received treatment with this CAR. They had received a median of 7 lines of prior therapy before CAR. 10 patients developed CRS, but all of them were just grade 1, and there was no neurotoxicity. Overall response rate of 72%, CR of 19% in 1 year, progression-free survival 36% in 1 year, overall survival 94%. We have a 1606, which is similar to 1532 with the CD30, but it also adds the addition of CCR4 to the CD30 antigen. And the thought is that the CCR4 is more of like a homing mechanism, so it can really help the CD30 antigen find its antigen target and have better penetration and hopefully kill off more cancer cells. This is still an ongoing study. And then we have 1541, which is our suicide switch. So this is a CD19 CAR that has an embedded capsase 9 safety switch. And then you can give a medication called remeducid to really activate that switch. So if a patient has severe CRS or neurotoxicity in this study, you would give remeducid. And when it activates that switch, it kills off the CAR T cells. Some mouse studies did show that cell death was dose dependent. So there may be the availability to kill a desired amount of cells, but still keep some of the CAR T cells active. And then some of our more exotic CARs at UNC, we have Charisma, which is for solid tumors. The no lymphodepletion on the one below actually goes with the Charisma. So for our solid tumors, they typically don't get any lymphodepletion. And this is our CAR macrophage. We have a metastatic ovarian one that gets 3 CAR infusions once a week, and then that's given in a peritoneal catheter. We have a pemphigus, which is a pharmaceutical-sponsored trial. This is that autoimmune CAR, and that's typically managed by dermatology. We have a myasthenia gravis, which is another BCMA CAR that's typically managed by neurology. And then some other ones that are ongoing. There's osteosarcoma and glioblastoma. So quite a few CARs on the horizon with, I'm sure, more to come as well. These are references and any questions.
Thank you, Megan, for sharing your expertise. This was really great, and I know I learned a lot. And just a reminder, if you missed last month's lecture or are looking to take a deeper dive into ICANS or CRS, Bijal Kakani shared with us her expertise, so you could find that in the self-paced webinars. So you could check that out. So Poll Everywhere is open for questions for Megan, so you can add your questions in Poll Everywhere, and we have a few minutes before we wrap up to ask Megan those questions. So I will start us off while we wait for some questions to come in. So I think I understand, because this is not my area of practice, but that CAR-T is essentially for refractory disease. Like, essentially, what line of therapy are we using CAR-T?
Yeah, so it's often one of the later treatment options currently. I think in the future, it may be used more as a frontline or earlier. But right now, a lot of times patients have to have failed multiple other therapies beforehand.
Great, thank you. And you had mentioned that given that long timeline of getting it approved and getting the cells and all of that, that sometimes patients can not go on therapy due to progression. Can you define that a little bit further? So what factors would prevent somebody from moving forward with that?
A lot of times it's driven by trial patients. So often they have set guidelines on the degree of progression that may prohibit a patient going on. Unfortunately, if patients deceased, then they can't go on to CAR-T. Or sometimes if patients just have really bulky, significant disease progression, there's concern the toxicities are going to outweigh the benefit. So that's really a discussion that has to be had with the patient and their attending, as well as the CAR-T team.
Yeah, so those similar kind of goals of care discussions in the refractory setting. So we do have a question. Can you review grade 1 ICANS supportive care one more time?
Sure. So with neurotoxicity, some of the supportive care measures are going to be things such as aspiration precautions, kind of really managing if patients can swallow okay. If not, we may need to switch their medications over to IV, switch their nutrition over to IV. A lot of times they're going to need hydration support from that standpoint. Really just making sure that they're not having aspiration risk. And then neurology, again, getting them involved early is going to be a key supportive management as well for them. And then we typically will move these patients off to the neuro ICU pretty quickly as well if they're progressing, just because they're going to be better equipped to manage with that.
So I know it's 5 o'clock. I want to be respectful of your time. Are you okay moving forward with one more question? And we will wrap us all up. So what is the expiration time for the CAR-T cell product? Can treatment be delayed for a while if necessary?
Don't know if I know the exact time, and it may depend on if the cells get frozen or if they're fresh. If they're frozen, they may be able to last a little bit longer. Then if it was fresh, it's going to have a much shorter shelf life. But I can get back to you. I don't know the exact expiration time for those.
And are these therapies typically given in the hospital or clinic?
So right now, most of them are outpatient. Some reasons we would do them inpatient would be if it's study driven and it requires it to be inpatient, especially for kind of early phase studies. And then some of our commercial products, if a patient has high comorbidities, we have concern for high risk for toxicity, we will do those inpatient. Or some of the products like Abecma, because we know they have such early onset for those toxicities, we will typically do that inpatient as well.
Great. Thank you again, Megan, for spending your afternoon with us and your expertise. I appreciate you being here. And thank you to the University Cancer Research Fund, to the UNC Lineberger Comprehensive Cancer Center and the Cancer Network for supporting this lecture series, and to our amazing telehealth team that are behind the scenes, making all the magic happen. Thank you to Tim, Benny, John, Oliver, Andrew, Patrick, Lindsay, and Barbara.